I'm going to talk to you about inflammation, pain, and urogynaecological disorders, particularly relating to uh, patients with joint hypermobility syndrome. We often see patients with joint hypermobility, and we'll see these rashes appear. And this is a patient after treatment, and the rashes had disappeared. Inside the bladder, we will see ulceration. This is a very inflamed bladder, and as the bladder is filling, a whitish scarred area appears, and what will eventually happen as the bladder fills, around the edge of the scarred area, we will see bleeding. And when we look in the bladder of women with joint hypermobility syndrome, we will often see these hemorrhages. And more importantly, when we biopsy, we see not only on histology excess numbers of lymphocytes, these are the innate lymphocytes, but we will also see mast cells. And there are very specific ways of counting these cells. And the upper limit of normal is accepted at 28 per square millimeter. There is a problem in that, particularly, for example, in United States, biopsies are normally done in the office under local anesthetic using a flexible cystoscopy, and the biopsy sizes are too small to allow an adequate count to be undertaken, because if the biopsy is less than a millimeter cubed, you cannot get a count per square millimeter. And for this reason, the guidelines for the American Urological Association do not recommend biopsy. Whereas in Europe, where biopsies are done using a rigid cystoscope under a general anesthetic, the biopsies are around 4 to 5 millimeters in size, and therefore an appropriate count can be obtained about histology. And the reason this is important is that the image, or what we see in the bladder, is not directly related to the histology. So there is a disconnect between what is seen and what is found on histology. And therefore, looking inside the bladder can be very misleading. And it has meant that a number of urologists in the United States would actually not even do a cystoscopy unless they wish to exclude a cancer diagnosis. Now, something which has been found in bladders are bacteria living in the cell wall. And here we can see this is actually a mouse bladder, and these mice were infected with E. coli, and it was found that about a third of the mice generated an excessive inflammatory response, which meant that the cells which line the bladder are actually shed. The bacteria then invade the bladder wall, and this is a scanning electron microscope where you can see the bacteria living as a biofilm in the wall of the bladder, and these cause repeated infections. Now, what's quite important about this is that you may remember I said only 1/3 of the mice did this. Another third of the mice, their bladders did not respond to the bacteria at all. So the lining integrity was maintained. But when looking at the urine, there were a lot of bacteria in the urine, but the bladder was not inflamed in the slightest. And those mice had a very poor innate immune response. And then there was a middle group of mice where the infection was actually cleared spontaneously. And the important thing about that is that they almost have a sweet spot in relation to their immune response to bacteria, that it's not so aggressive that it disrupts the lining of the bladder and allows bacterial ingress, but at the same time, it actually gets rid of the bacteria. So we see these different states, and we see them also in humans. So these bacteria, what can they do? Well, there are good bacteria and there are bad bacteria, and I'm going to come to that in a second. It's quite important in relation to understanding how the bacteria interact with the immune system. The green bacteria are the commensal organisms. The brown bacteria are the pathogenic bacteria. And you can see that, sometimes the commensal bacteria will prevent pathogens from entering. They will also destroy, the commensals will destroy pathogenic or harmful compounds. They may also produce antimicrobial compounds against pathogens, and also they'll crowd it out. So it's a little bit like a safari park where you'll have good bacteria fighting off bad bacteria. It's like having the lions and the antelopes. If you've got too few lions, you end up with loads of antelopes. But they also, interestingly, generate neurotransmitters, which certainly in the gut have been found to alter brain function. And they also can encourage the epithelial or defensive functions of the cells. So what do we find in the bladder in terms of symptoms and these bacteria? And we can see in this study, which compared women with urgency urinary incontinence, they have urinary symptoms, compared with women who have no urinary symptoms, that the number of bacteria are much higher. So this is using DNA technology, PCRs, and looking at the number of bacteria present. We've got to be a little bit careful about this. 1/3 of the bacteria, we don't even know, we haven't even described these bacteria, but it shows that there is an increased diversity of organism inside the bladder, looking at the urinary microbiome in women who have symptoms. And we know that people with joint hypermobility have a much higher rate of urgency and urgency incontinence. And when we look at comparing the different types of bacteria, so the blue are the lactobacillus, and we find the lactobacillus in the vagina and the bladder. And you can see that in the patients who have no urinary symptoms, the controls, many more just are dominated by lactobacillus. And we see many more women who have incontinence problems with high levels of Gardnerella. And this is inside the bladder. These were castor specimens. And we also see more Enterobacter, which it should really be a gut organism, and it's starting to live in the bladder itself. And lastly, Staphylococcus, the one in light blue. And this is not an organism we would normally expect in the bladder. And quite often, microbiologists will say, oh, this is a contaminant, it's a skin bacteria. Sadly, that's not true in these patients with urinary symptoms. We see staphs and streps in these bladders. And when we look at the response to treatment for overactive bladder, we can see these are the number of bacteria species found on the urinary sample using a catheter, and these are the number of patients. And we can see how the women who responded to drug treatment at a lower dose have a lower number of bacterial species. The ones who had needed a higher dose of drug treatment had a much higher level of bacterial species. And then those who did not respond had an even higher diversity of bacteria. So diversity appears to be related also to the response of these women to drug treatment. So what is it that is being seen? Because this is about inflammation and allergy. And remember that these overactive bladder patients, over 55% of them, will have joint hypermobility spectrum disorder. And on bladder biopsy, we find these lymphocytic, monocytic infiltrates and suburothelium. And urinary cytokines can be used to assess the sorts of cells in the tissues. And low levels of cytokines do not mean low levels in tissues. So we're going to be a little bit careful. If we find the cytokines in the urine, then definitely the cells are in the tissues. But if the cells are not activated, we can sometimes then, when we use the urinary cytokines, miss the inflammatory cells which are present. So this group, which is in Detroit and Pittsburgh, they looked at controls in gray and the overactive bladder patients in white. And this is a logarithmic scale. So this is actually a huge difference when you see these differences. So this would be this is a tenfold increase. And you can see that quite a number of these chemicals are elevated, in particular the MCP1, the IL-5, the IL-10. But what do these things mean? Well, there are 4 families of cytokines, and the most important are the CC class, MCP1, which is the mast cells, the CXC class, which are the neutrophils. So neutrophils normally deal with bacteria. And interleukin-5 suggests eosinophils. Interleukin-10 suggests inflammation just due to trauma. And that's quite important that we don't just ascribe everything to inflammatory cells, and it could just be the bladder being stretched. And this is what was seen looking at the different groups. And again, remember, this is a logarithmic scale. So there's a huge difference here between these two. So this is the mast cells, and we can see there's a significantly higher level of mast cells in the overactive bladder patients compared with controls. When we look at the marker for neutrophils, it really, even though it's significantly different, there's probably a subgroup somewhere in this, but there is a great overlap. Looking at the IL-5s, which are the eosinophil group, again, it's significantly higher, but there is a degree of overlap. And lastly, the sterile trauma, it's again higher, but there's quite a marked degree of overlap. But could this just be because these women are infected, their bladder's infected, and it's not really anything to do with having an overactive bladder? It's actually more to do with having a urinary tract infection. And so looking at the same groups of cytokines, we can see that apart from the CXCL1 group, which would be really looking at the neutrophils, there is an elevated level compared with in the UTI group compared with overactive bladder and controls. But looking at the other ones like the sterile trauma group, there's actually no, if anything, the controls have a higher level, and everyone else, there's a great deal of overlap, but there are a few outliers which are much higher, which we would expect because there's going to be an immune response to an infection. So what's really happening here? Well, there's certainly, we can see that there can be an abnormal level of bacteria, and we see this increased diversity in the bladder of bacteria. There's an interaction with the innate immune system. So this is very important. It's not an antibody-based problem. And I'll be talking about COVID in a second, which is very much a T cell response. And this interaction between the bacteria and the mucosal innate immune response leads to either a weak to moderate host response, which self-resolves the infection. A weak or absent host immune response leads to a persistent bacteria, so bacteria just in the urine, but the bladder's not inflamed, or a severe inflammatory response with loads of markers of chronic cystitis, which we've seen. And then we end up with this constant interaction between the bacteria and the bladder wall. So inflammation, infection. And what's important about this is that they do not need high levels of bacteria. So these patients, we've certainly looked at the level of bacteria which elicit an immune response, and they need a much lower level, between 10 to 100 times lower levels of bacteria induce an immune response. And this is important because when we look at joint hypermobile patients, first of all, urine analysis. So that's testing the urine and looking at the white cells and blood in the urine. Because the immune response is different, urinalysis, we only find positive in 10% of patients with joint hypermobility who have a UTI. Whereas in the general population, it is positive in 90%. And as it's used as a key screening tool, a number of, we've certainly studied this in women, will be told that they do not have a urine infection when on urine culture, an organism will be found. The second important thing about urine cultures is that in line with the American Urological Association, the Canadian Urological Association, and the European Urological Association guidelines, cultures should be taken to 1,000 culture forming units per mil, which is 100 times lower than is reported in most institutions. And the reason for that is that in this group of patients, we will find these lower levels of organism. And what do we see? We see this interaction between the immune system. We see all those cytokines, which we spoke about, the mast cells, and they cause the lining of the bladder to shed its outer coating. They get this exfoliation. We get colonies of bacteria living in the bladder, again, causing the immune system to become more inflamed. And we see the cycle of infection and inflammation continuing. But what is it specifically about the immune system which causes problems in patients with joint hypermobility? And here we are looking at mast cells and histamine. Mast cells contain up to 30 different chemicals. They cause increase in sensory pain. They cause inflammation, edema, and leukocyte migration into the tissues. We have another part of the innate immune system, which is the complement system. And this allows, by the use of lectins, to bind bacteria, causing a triggering of complement, which then causes more inflammation and destruction of cells. And then lastly, we have the mannose binding lectin, which is found on, this is the foot of a macrophage, and it allows the macrophage to attach to a bacteria and then pull the bacteria in. So here we can see scanning electron microscope of a macrophage, and you can see the foot being put out, and it sticks to the bacteria. And by doing that, here you can see them pulling the bacteria in towards the macrophage. Now, if you don't have the mannose binding lectin, you cannot bind the bacteria. So it's almost like having slippery gloves trying to pick something up. So very important for getting rid of bacteria, having mannose binding lectin. So what do we see in women with, this is actually a group of women with hypermobility spectrum disorder who have, this is 667 women, and 40% have a reduced level of diamine oxidase. So this is the major enzyme for destroying histamine. So that if mast cells, the person can have a normal level of mast cells, but if they release histamine, the actual ability to destroy it is reduced. So therefore the person ends up with excessive levels of histamine and ends up with those skin rashes that we saw earlier on in the talk. 35% of these women had reduced mannose binding lectin levels, and these were associated with recurrent UTI. So they find it more difficult to get rid of bacteria because the macrophages just can't grab hold of the bacteria. And in the background population, reduced diamine oxidase is 5%, and mannose binding lectin is between 5 to 10%. So we can see they're much higher levels than we would expect in the general population. When we do biopsies of the bladder, we find that there are increased levels of these mast cells, and the cutoff is 28 mast cells per square millimeter. And we found increased levels of these cells in over 40% of patients. And this means increased mast cells mean that they release more histamine, which then lead to more inflammation, redness, pain, swelling. And if it's in the bladder, it's probably elsewhere. And there is the association with the number of copies of the serum tryptase gene. This is Lyons from 2016, where they looked at 25 families with EDS, and they were investigated for fatigue, fibromyalgia, irritable bowel, and skin rashes. And they found that the worse the symptoms, the increased numbers of the alpha tryptase gene. So what do we normally suggest to patients with increased mast cells in the bladder? Well, we ask patients to stop eating mast cell liberators, so things like cumin, chili, tomatoes, aubergine, chocolate, gluten, taking vitamin C, 750 milligrams twice a day, using a type 1 antihistamine such as loratadine, 10 milligrams twice daily, type 2 antihistamine such as famotidine, 40 milligrams once a day, and quite key, ketotifen, which is an old drug. It's in the antihistamine family, but it's a mast cell stabilizer, and it also interferes with the leukotriene pathway. It was used for childhood asthma, and we suggest ketotifen starting 0.5 milligram at night for 8 nights, then increasing up to 1 milligram, and it can actually go up to 2 milligrams twice a day. The important thing is there are studies on the gut showing that ketotifen actually reduces the number of mast cells in treatment. So that's a pretty important thing for not a drug which really doesn't seem to have very many side effects. The main side effect is drowsiness, so it's taken at night. And what about patients who have a lack of diamine oxidase, so have histamine intolerance? Well, we go for a low histamine diet, no pickles, chilled meals, protein-rich foods which are not frozen. So basically, if somebody wants pre-prepared foods, they are best frozen. But really, you want something where bacterial activity will not be acting on the protein. And patients may well take a food supplement such as diacin before eating foods. And the mainstay of treatment is using a type 1 antihistamine such as loratadine, 10 milligrams twice a day, or a type 2 antihistamine and a type 2 antihistamine famotidine, which is 40 milligrams once a day. Now, we've seen a lot of COVID-19 viral infections. And by November last year, there were 247 million cases with 5 million deaths. There's certainly initial resolution of acute viral symptoms, followed longer-term symptoms in 5 to 30% of patients. And the symptoms range from pulmonary, neurologic, dermatological, cardiac, urogenital, endocrine, and autoinflammatory. Long COVID, which is a multi-system disease after SARS, the etiology is unclear, but it's more likely in women and, importantly, young women. And it often follows mild illness, and there appear to be persistent changes in the T cell subtypes in these patients. And they complain of fatigue, urticaria, food intolerance, bloating and diarrhea, brain fog, nocturia, and bladder pain, sweats, myalgia, joint pain, breathlessness, headaches, anxiety, insomnia, and postural tachycardia syndrome. Now, this is from a US study. Difficulty with this was that it was a small group of men and women who had actually had very severe COVID and had continuing COVID symptoms afterwards. So they may be actually quite a specialized group. They complained of urinary frequency and nocturia. The nocturia seemed to be quite a key symptom, but they also had urgency and incontinence. So just thinking back to the data which I presented earlier, and they had significantly elevated urinary cytokines, interleukin 6 and 8. They had an increase in bladder pain, increase in pelvic pain, and importantly, we have found since COVID that there are more recurrent urinary tract infections, especially Klebsiella infections. Klebsiella prior to COVID was about 4% of urinary tract infections overall, 11% in care homes. We now find it 60 to 70% of our patients. There's also an increase in nocturia, and we've now found increased numbers of mast cells in the bladder and increased microscopic hematuria. So blood in the urine, which we can't actually see, but on testing we can find. And we also found increased levels of cherryangiomas on the skin and urticaria. And looking at flow cytometry in the blood, Glynn and et al. Found increased CD4 and CD8 cells, reduced in the blood, but subsequently increased in the tissues. So basically these cells, these T cells are going off from the blood into the tissues, causing inflammation. And interestingly, these were groups of men and women, not specifically joint hypermobility, but with long COVID, and they gave them loratadine and famotidine and ketotifen over a month, and there was a 72% reduction in symptoms. They're actually symptoms resolved. And what we found subsequently, if there's a bacterial infection, obviously I'm looking at bladders, if the bladder infection not treated, the symptoms in that organ do not resolve. So quite often the patients will say their brain fog, fatigue has disappeared, but if there's an organ which specifically still has symptoms, one should be looking for some kind of infective etiology in that organ. Certainly that's what we found in bladders. So in conclusion, bladder pain is part of a systemic reaction to bacteria by the immune system leading to pain. In women with joint hypermobility, 40% will have low diamine oxidase. So their ability to destroy histamine is impaired, and they will have excess numbers of they will have excess amounts of histamine in their body, leading to pain, inflammation, and swelling. A further 40% will have excess mast cells, we've certainly found in the bladder, and this will mean that they overproduce histamine, even though they may have normal levels of enzyme. So their ability to destroy histamine will be normal, but they will have an excess number of cells. And 20% will have elevated levels of both. The reduced diamine oxidase activity, or mannose binding lectin, leads to more urinary tract infections and or inflamed bladders, secondary to an excessive innate immune system response. Treatment of these patients, diet is key, and the use of antihistamines and mast cell stabilizers such as ketotifen. COVID can lead to a prolonged symptomatic disease which can affect the bladder. It's more likely to be women and younger people, and there are changes in the T cells which have been detected. The patients complain of symptoms of bladder pain syndrome and overactive bladder, and the treatment involves the use of antihistamines, the type 1 antihistamines to block histamine production and its effect on the tissues. The type 2 histamines, such as famotidine, have been shown to have an impact on the innate lymphocytes. So it actually, in a way, shows how both work in different ways. And then lastly, using mast cell stabilizers to calm down excessive mast cell activity and resolve it. And lastly, importantly, any infection in the bladder needs to be cleared, because there is an interaction between infection and inflammation, and a cycle is produced. And only by breaking the cycle do we stop the whole problem. Thank you very much.